when they come with parotitis pictures, pain, fever. So that will be your bacterial or viral. Okay. The systemic. The systemic and autoimmune is sort of overlaps with Sjogren's syndrome and your obstructive. Always remember, obstructive causes recurrent parotitis. That means your duct is obstructed. Okay. So the three things that mainly causes your obstruction. Okay. One is either it is stenotic, that means it is small. One is silolith, which is basically a stone there, and the other one can be an impacted, like mucus plug. So when the mucus plug causes this obstruction, then it causes all the swelling, state what do you call it? Stasis of the saliva, causing mucocele, causing ranula if it's your sublingual duct. Are you all with me?
Yes, doctor.
Yes, doctor.
Okay, I'm so sorry. This is my first online class, so that's why. Okay, next. So salivary. Now we are coming to uh the the clinical symptoms part of it. Okay, so when there is a swelling, it's either from the major or the minor salivary gland in the oral cavity. Okay, these are the symptoms. Okay, then you can have pain on swallowing, dryness of the oral cavity, or excessive salivation, discharge from the duct opening, and foul smelling discharge. Okay, next. Okay, so the approaches to the patients with salivary gland disorder. Okay, you have to get proper history. Okay, so it is past or present history, whether there's any surgeries done before, any radiotherapy, any systemic problems, and any medication they are taking. And also clinical examinations, which is 4 clinical measures to diagnose the hypofunction of a salivary gland. That means the gland is not functioning optimally. Will be your dryness of the lips and buccal mucosa, absence of saliva production by the gland, bimanual palpation. Bimanual palpation is mainly for your submandibular gland. Do you all know how to do the uh, bimanual palpation?
Is when we ask the patient to turn their neck a bit to the left side and then we palpate like that.
No. So bimanual palpation is basically in your submandibular gland, right? You all know where your submandibular gland is situated. When there is a swelling there, you put your finger intraorally at the floor of mouth laterally. That means just below your premolar, around that area. And then you push the mass from below. That means the swelling from below, and you feel whether is it mobile and is it touching the tip of your finger intraorally. Do you understand? Yeah, so when you push the submandibular swelling from bottom, you can feel it hitting the finger intraorally. So that's bimanually palpable. So that's how you differentiate between a submandibular gland swelling and a lymph node. Because a lymph node is not bimanually palpable. Okay? Next. So the investigations for a salivary gland tumor or infection would be imaging of the salivary gland, xylography, special imaging, cytochemistry, biopsy, and culture if there is any pus or tumor suspected. Okay, next. Okay, various conditions will be a xerostomia. You know what xerostomia? Does anyone can tell me what xerostomia?
Dry mouth,
Yes. And what's your silolithiasis?
salivary stone,
Okay, good. Uh, next. Okay, so xerostomia is a subjective sensation of oral dryness. Basically, it's dryness that may or may not be associated with reduction of salivary output. Okay, it can be temporary or permanent. Okay, and the usual causes can be psychological, drug, dark calculi, which is a silolithiasis causing obstruction and reduced salivary gland, infections, inflammation, trauma, salivary gland aplasia, and radiotherapy. I'm sure you all see a lot of patients post radiation with xerostomia, right?
Haven't yet, doctor.
Okay, okay, sorry. You all are in which year now? Sorry,
Year 3.
year three. Okay, okay. Next. Okay, silolithiasis is basically a stone within either the duct or within the gland itself. The most common salivary gland to have this is your submandibular gland. Okay, okay, and it is mixtures of different calcium phosphate, as stated. Okay, and then the calcium salts are precipitated due to supersaturation and deficit of the crystallization inhibitor. Okay, next. Symptoms would be pain and swelling after meal. Okay, there's no association between siloliths and either nephrolithiasis or cholelithiasis. Do you all know what's nephrolithiasis or cholelithiasis?
Kidney stones and gallbladders. Right?
Yes, yes, very good. Okay, so the diagnosis: a plain X-ray films miss 15% of calculi due to insufficient calcification. So a recommended cytogram or ultrasound scan would be good lah. Okay, next. So sorry, I just 1 minute. Okay, so approach to patients and how do we diagnose these patients? Okay, so approach. So basically, whatever that is in this chart here, the congenital inflammatory infection are all the possible causes of a pathology in your salivary gland, which is not associated with the tumor. Okay, so this I think you all can go through it, right? Because it's quite in detail and it's a very good flow chart actually. Okay, for the possible causes. So when you rule out, when you get, of course, history taking is always important. So based on the history taking, you can sort of narrow down this possible diagnosis based on the duration of the swelling, the nature of the swelling, and whether it's painless or painful, age related. History is always very important. Okay, so these are the ones, the possible causes lah, which is not associated with non-neoplastic. Okay, next. Okay, see, you have to obtain patient history. This is, and then you perform a physical examination. So based on that, you can see if it's a localized disease or is it secondary to a systemic disease. When it is, when you suspect if it's a localized disease, then you see based on the history whether it's, like I said, the duration, whether is it acute silodenitis or is it chronic or recurrent. Okay, and if it's acute, most of the time you think of an infection lah. Okay, in a non-pre-existing swelling. Okay, that means there is no swelling there previously and suddenly they've got like 2 days history, then you suspect it's an infection. Okay, and if it's recurrent or chronic, Then you can think of all the ones stated below lah, whether is it obstructive or non-obstructive. Okay, and if it's obstructive symptoms, you think of the three things I told you. It's always obstructive will be either a stone, whether a mucoplug causing an obstruction, or whether is it a stone or a stricture. The three things, sorry. Okay, then you treat accordingly. If it let's say it's a stone or stasis or a stricture, then that's when we're going into side endoscopy, which is basically putting a camera through the duct. First you dilate the duct, and then you put a camera in, and then you sort of dilate it. If there is a stone, you remove the stone. If it's non-obstructive, that's when you go do a biopsy. How do you do a biopsy? So what's so special about salivary gland is, right, you cannot just cut and do an incisional biopsy or anything like that. The main, the ideal investigation is to do a fine needle aspiration cytology. Okay, whether it's image guided or non-image guided. Okay, and then you come up with a possible diagnosis lah. Usually FNAC is quite sensitive, but if you can't, even if FNAC fails, you always have to do, if for the parotid gland or the submandibular gland, you cannot do um sorry, you can't do a true cut biopsy or incisional biopsy. It's contraindicated. So what you do is, if it's a parotid gland, then you got to do a superficial parotidectomy, and then you take that mass and send for HPE. If it's a submandibular gland, you do a submandibulectomy. We always try to avoid, not avoid, we never do an incisional biopsy for a salivary gland. Okay, and then it's your systemic as stated there lah. So systemic, you gotta rule out other things, whether they're autoimmune causes. You do all their viral screening, the autoimmune screening, and then you refer, so on and so forth. Next. Okay, so development disorder is atresia or aplasia. Atresia is basically congenital absence of salivary ducts. Okay, and aplasia is complete absence of one or more salivary glands, with or minus other disorders lah. Okay, next. And then inflammatory, like I said, adenitis is an inflammation condition affecting the salivary gland. Parotid salivary glands are the most commonly affected. Okay, adenitis is either infection or non-infectious. Sorry, infectious or non-infectious. Next. Okay, so if it's infectious, it's either it's actually basically the same thing lah, whether it's bacterial or viral. Bacterial would be your Staphylococcus aureus or pyogens, and then Streptococcus viridans. This is it lah. So your Staphylococcus is the most common, and then in virus, mumps is the most common lah. But usually viral mumps you usually get bilateral. Very rarely you get unilateral. Okay. Next. Okay, next. These are basically repetition from the flow chart. Next. Next. Okay. So have you heard of sarcoidosis?
Yes.
Okay. So, okay, next. Okay. So, hello. Sjogren's syndrome is actually an autoimmune disorder associated with HLA-DR3. Okay, so the clinical features of it is it's either primary or secondary. Primary, your patients will come in also with associated symptoms such as dry eyes. Okay, and secondary, it develops with other diseases lah. It is most commonly seen in women more than 40 years old. Okay, the ratio between female to male is about 1 to 10. That means it's 10 times more common as compared to male. Okay, next. Okay. Uh, to diagnose the Sjogren syndrome, you must have at least two out of the three following criteria, which is your laboratory findings, anti-salivary duct antibodies, anti-nuclear antibodies, which is your ANA, your rheumatoid factor, increased ESR, and also lip biopsies, lymphocytes around your salivary gland. Your lip biopsy, sorry. Normally they take it from your, see there's a photo here that is showing where that you take the biopsy to roll it up. Okay? Yes. So these are the criteria based on the American College of Rheumatology classification. So at least two out of these has to be positive. You know the box in orange above the biopsy photo? This one. Okay. And the treatment for it is basically symptomatic treatment. For the eye, you give artificial tears because they tend to have dry eyes, and then saliva substitute, fluoride applications, and oral hygiene. Okay, next. Um, next. So for the traumatic, uh, so this is one of the reasons where sometimes we do not do like all this like I said incisional biopsy or any open biopsies for salivary gland. These are one of the causes. It can cause mucocele or ranula. So how does this mucocele happen is basically rupture to the salivary duct. So there's spillage of mucin into the surrounding tissues. So clinical feature will be bluish thin wall lesion, which is fluctuant at the lower lip. This is for uh, minor salivary glands lah. And granulas are basically it's stasis, right? So it is mucosal which grows in the floor of the mouth, and then it's unilateral and similar appearance to enlarged abdomen region of the frog. You know, the patient, if it's like plunging ranula, if it's just a simple ranula, it it is present intraorally at the floor of the mouth. When it goes through the uh, mylohyoid muscle, that's when we call it plunging ranula. So it goes into the neck. That means you look like the frogs. I don't think you see like the picture here. Can you see that picture? Yes, that is just a simple ranula. When it goes, it breaches through and it passes beyond the myohyoid muscle. It comes out in your submental region. That is your that's called plunging ranula. Okay. So basically, if it's just a small, simple one like this, you can excise it. But if it's large, then you marsupialize it. Okay, next. So salivary gland tumors. Salivary gland tumors can be either next. Next. Okay. So it can be either benign or malignant, like I mentioned earlier. So next. Okay. Next. Okay. So these are the common ones. Okay. You have a lot of tumors that can arise, like the previous slide, they showed from the WHO. But these are the common ones. I think if you focus on the common ones, you'll be on the safe side now. Because otherwise, there's just too many. So common salivary tumors, based if it's benign or malignant. So the most common benign tumor is your pleomorphic adenoma, your canalicular adenoma, papillary cyst adenoma, ductal cyst adenoma, and your cile adenoma papilliferum, which I've not seen. The commonest is your pleomorphic adenoma. Your malignant is your mucoepidermoid carcinoma, your adenocystic carcinoma, um, your low-grade adenocarcinoma, and acinic cell adenocarcinoma. Okay, next. So this shows the incidence. So malignancies are most common in minor salivary. Okay, and the benign is more common in your parotid gland. Is it? Sorry, just 1 minute. Yeah. I'm so sorry. Yeah. Yeah. So this is basically it. Okay, your benign tumor in your parotid gland is about 80% of head and neck. Uh, I mean, sorry, it's most common in your parotid gland. Your benign tumor, benign. So the commonest is your pleomorphic adenoma, followed by your wartins in your parotid gland. Okay, whereas malignancy, you see, mucoepidermoid is the most common. Adenocystic is common, but in your minor salivary gland. So from this chart, it shows you that parotid gland mass mostly is benign, which is your pleomorphic. Minor salivary gland is malignancy is more common in minor salivary gland. Next, next. Okay, so pleomorphic adenoma. Pleomorphic adenoma, like I said, it's a benign salivary gland tumor. Okay, it exhibits wide cytomorphological and architectural diversity. The tumor has the following three components. It has your epithelial cell component, your myocell component, and your mesenchymal component. Next. Okay, this is basically the HPE of a pleomorphic adenoma. Next. Pleomorphic adenoma, like I said, is the most common salivary gland tumor in both children and adult. Okay. It occurs in individual at any age. Okay, but it is the most common in your third to the sixth decade. Okay, and the management would be parotidectomy. Okay, yeah. So this is the incision for a parotidectomy. Most of the time, we just do depending. We investigate first with a CT scan. Then you see the extent of it. If it's confined to the superficial lobe, we do a superficial parotidectomy. So superficial parotidectomy, we do this incision. Can you see it extends from your zygoma below your lobule? It goes behind the mastoid tip, and then we come down following your crease. So this is called the modified Blair incision. Okay, next. Okay, malignant changes in a pleomorphic adenoma can occur. It's about 2 to 7% of cases, and it's and shows some association with multiple recurrence, deep lobe tumors, and male gender and in older older age. That's why in a patient with pleomorphic adenoma, even though it's benign, we always advise the patients to remove it because there is a risk of malignant changes, transformation later. Okay, and this would be called a carcinoma ex pleomorphic adenoma. Okay, next. Okay, next. Next. Okay, next. Okay, now malignant changes of children is is actually about 5 to 10%. Okay, in about usually in about 10 years lah. We're talking about 10 years. Okay, and it commonly becomes the common malignancy. The malignant transformation is lymphoma. Okay, next. And like I said, carcinoma ex pleomorphic adenoma is a risk of a 10% risk in 15 years for it to become a carcinoma ex pleomorphic. But of course, this is all just statistics. It can happen earlier, it can happen later, it may not even happen. Okay, next. Okay, so a salivary gland tumor can be classified as low grade, intermediate, and high grade. Okay, next. So the low grade ones, see mucoepidermoid carcinoma itself can be either low grade, high grade, or intermediate grade. Okay, then you have your low grade adenocarcinoma, your acinic cell carcinoma, your basal cell carcinoma, and your polymorphous low grade adenocarcinoma. And then you go to the next intermediate grade, will be like I said, your mucoepidermoid intermediate grade, intermediate grade adenocarcinoma, and your oncocytic carcinoma. Next. And the high grade. The high grade would be your high grade mucoepidermoid carcinoma, the adenocystic carcinoma, carcinoma ex pleomorphic, adenocarcinoma, and then squamous cell carcinoma, and undifferentiated carcinoma. Okay, and this high grade has aggressive behavior. It's locally invasive, and there is a risk of lymph node metastasis. So that's why sometimes FNAC comes back as pleomorphic adenoma. Then we do a superficial peritidectomy, but that comes back as carcinoma ex pleomorphic adenoma. Even though the deep lobe is not involved and there is clinically no neck nodes, we still have to explain to the patient that there is we have to go in for a completion peritidectomy, basically to remove the deep lobe, and we will proceed with a selective neck dissection if the n is 0. If it's n1, then we proceed with with a modified radical neck dissection. Okay, next. Okay, symptoms or and signs of salivary gland. Next is basically you still the mass, like I said, the duration, the rate of growth, the presence of pain, and then the nerve, whether the facial nerve is involved or not, and notes, whether there is any palpable notes. Next. Okay, so the mass itself, whether it is uh, hard, firm, okay, whether it's firm, whether it's hard, the size, the consistency of the mass, the location of the mass, and then clinically has it eroded, whether the patient has any facial nerve palsy, okay, and then whether there's intraoral, that means there's any medialization, then you suspect there's deep lobe involvement as well. Okay, next. Okay, next. Okay, this TNM staging, you all just have to go through yourself. Next. Okay, so the management strategy, like I said, is based on patient factor and the tumor factor. When you say patient factor, you say the age, the comorbids of the patient, okay, and whether the patient is fit to go under a long surgery, because this will definitely take at least more than 4 hours. Okay, the risk of GA. And the tumor and the grading. The tumor per se, the extent of the tumor, whether it's operable or not, whether is it encasing the major vessels, okay, and whether the how much has it gone, and it's eroded the base of skull, okay. So basically, whether the tumor is operable or not, which is removal of the tumor, okay, and if presence of facial nerve, whether the patient nerve is intact or not, whether the patient will need extra surgeries, like sometimes parotid tumor can extend into the temporal bone, like mastoid through the ear. So this one, the patient will need like a temporal bone resection, whether any other mandibulectomy, whether the facial nerve needs to be sacrificed or not. These are all important things. Okay, next. Next, please. Sorry. Okay, so this is management of salivary gland tumor. Okay, surgery, very parotidectomy. Like I said, if it's benign, usually, even if it's benign, we usually it's confined to the superficial lobe. But there are benign tumors that extend into the deep lobe, so that's when you do a total. But most of the time, we just do a superficial. And then if it's malignancy, you have to do a total parotidectomy, and with or without the neck, addressing the neck. Okay, if it's high risk based on FNAC, then we address the neck. Are you all following? Am I going too fast?
No, doctor.
Okay. And then you see whether the patient needs any adjuvant radiotherapy. Okay. Okay. So basically, parotid gland, right? It's you all know the anatomy. It's like a burger. So the top braid is your superficial lobe, and then you have the patty. The burger patty is basically your facial nerve. It runs in between. And then the lower braid is your deep lobe. So can y'all sort of understand? Okay. So next. Okay. So survival prognosis is always whether there is the age related, whether the staging of the tumor, whether is it high grade, low grade of the tumor, the size, and whether there is nodal involvement or not, and also perineural invasion. Okay, perineural invasion, the commonest tumor in in a salivary gland which has perineural invasion would be your adenocystic. So sometimes a patient can come with very small parotid mass, but there is facial nerve palsy already. So you have to what do you call that? Think of adenocystic. Okay. Okay. Next. Okay. Next. So what is SAL endoscopy? SAL endoscopy is basically endoscope of the salivary duct, whether it's your parotid duct, which is your Stensen's duct, whether it's your submandibular duct or sublingual duct. Okay, next. Mr. Zahir is one of the head and neck surgeons in Malaysia that actually does silent endoscopy. Even in KL, I don't think anyone does it. In northern region, they all refer to Mr. Zahir lah. I don't think anywhere else they do it besides Mr. Zahir. Next. So this is the same one. Next. Okay. So in a recurrent salivary duct swelling, you see whether it's unilateral or bilateral. If it's unilateral, you can do an ultrasound, okay, or MRI silography. So the diagnostic style endoscopic, which is done here, we do it here in Penang GH. Okay, so you basically put a camera in. So you dilate the duct and then you put an endoscope through the duct. It's a rigid scope. Okay, you put it in. So based on this, you can see sometimes you see whether it's a small calculi which is less than 3 to 4 mm, you can use a wire basket and extract it. Or it's a medium calculi between 3 to 8. Okay, then you either do a laser lithotripsy with wire basket extraction. Basically, you sort of laser it and you break it down to smaller pieces and then you remove it. Or if it's very large, which is more than 6 to 8 mm, okay, you do a combined approach, which is silent endoscopy and surgery. So basically, you marsupialize it, or I mean, basically, you open it up and then you suture it to the sides. Okay, and even its stenosis, if it's a small stenosis, you can either dilate it or you do a balloon dilatation. Okay, a diffuse stenosis is mechanical dilatation. So we've got different sizes of our probe. Okay, it starts from 000 up to, if I'm not mistaken, 7. If I'm not mistaken, so you start with 000 and then you introduce the 00 and then you gradually increase it. Okay. Okay. Next. Yeah. So basically, that's how a silent endoscope is done. Can you see the one which the arrow is pointing to? That is your probe to dilate it. Okay. That's Mr. Zahir doing it. Okay. Next. Yeah. So this is the silent endoscope. Can you see? It's so tiny and it's going through the that's a sublingual duct. Okay. Next. Okay. So this is for the balloon dilatation, like I told you earlier. So you basically put it through the stenotic segment and then you open it up. You inflate the balloon, you leave it there for a minute or two, and then you deflate it. Okay, next. This is a lid, a stone within the parotid duct. Okay, and that's a basket removing it. Can y'all see the photo below? That's the basket. Next. So I think we have come to the last slide already. I'm really sorry if I've been rushing through. I hope you all understand because it's a big topic as well. I hope you all understand I've gone through the important bits lah. So I hope you all understood. So thank you very much. I think this is the last slide, right, Mark?
Yes, doctor.
Okay. Take care.
Thank you, doctor.
Okay.
Thank you,
Yeah,
doctor.
doctor.
Thank you so much. Bye.